So good morning again. I hope you all are doing well. The usual housekeeping stuff, I just want to mention we have CME that's available to you all. And I'm just going to go ahead and put the slide up here. So I'm sharing that now. And see, I'll send the link out here shortly. And then, of course, there'll always be the option for you to grab that CME at any time in the coming days, weeks, months through the link that CME set up for us as well. And that is also for any grad rounds that we've had since we started doing this COVID theme, as well as lots of other lectures from the Department of Medicine and throughout the School of Medicine as well. So if you haven't gone to that website to grab CME, do so. Thank you to you guys who asked so many questions last week. Same as last week, we're going to continue with the same theme of trying to answer all your questions as they're typed into the question and answer function on Zoom. And then later in the day, we'll try to get that out to you at the end of the day. Thanks to the communication team, Jack and his team, for putting that together online so you can access all those questions. And please do provide us feedback if that's working better. For us, we get to answer more of your questions and also hopefully provide more time for questions for our feature presentation today. So with that being said, Dr. Harrington, I'll turn it over to you.
Thanks, Errol, and thanks first to our panelists who have been carving out time every week. It really is an all-star group that gives us a perspective of the clinical issues, the laboratory issues across our entire system. So, and I think it's a good idea to share it because there are some generalizable lessons that we hope are helpful to people who are from outside the Stanford medicine system. I'm really pleased to see today a group of our colleagues from health policy and our primary care outcomes research group within the Department of Medicine. Is really fantastic that will be the focus today on health policy and reopening the economy. So with that, Errol, why don't I turn it over to you to walk through the panelists, and then we'll have a presentation by Doug and his team.
Great. So we'll start with the updates, and as usual, Dr. Rizk, we'll start with you.
Thank you. So if you could go to the next slide. We've been spending our time in the last week thinking about how we may come back to a more normal operating situation. And that's because the cases have plateaued in Santa Clara County, and particularly at Stanford, as I'll show in a second. There have been very few cases that are incremental. So if you look in the middle panel in the blue curve, you can see that it appears to be plateauing. There's no change in the pattern. The pattern of COVID cases in Santa Clara County is still largely middle-aged people. And the death rate, though, is in older patients, with about 3/4 of them being over 60 years old. There continues to be disproportional death rate in Latinos and African American compared to their base in the population. Go to the next slide. So, as we try to ramp up and get back to more normal operating procedures, we've really focused on expanding testing. And we now have 8 testing areas. We have both areas for asymptomatic healthcare practitioners, for both swabs and serology, and for symptomatic patients. So this has really been scaled. Next slide. And last week on Monday, Song Chang and Occupational Health did an amazing job of increasing the numbers tested. So you can see in the uppermost curve, the 11,102. It's a couple days old now. But that's the total cumulative SHC employee tests. And a number of them, like 7,500, had both tests, that is serology and real-time PCR. And if you go to the next slide, you can see that we're doing this across all aspects of Stanford medicine. So Stanford Healthcare on the top, Stanford Children's Health, School of Medicine, Valley Care, UHA, the Pediatric Network, et cetera. Next slide. So in the first roughly 6,000, what we determined in our asymptomatic healthcare workers is that there was only about a 0.7% positivity rate. And if you took out those that we already knew had COVID and just looked for asymptomatic patients that were newly discovered, it was actually only 0.4 of 1%, i.e. 1 in 250 asymptomatic healthcare workers that have been tested at Stanford are positive and asymptomatic. The serology testing, which is largely done to understand the epidemiology of our ecosystem and who's been exposed to date, shows IgM results at 3%, IgG results at 1.6% in our asymptomatic population. So for all of this, I'm indebted to Song Chang, and he'll speak briefly in a minute. But the message is that we are doing very widespread testing now. We intend to test all healthcare workers at Stanford, and that in addition to our access control and screening at the door, and our testing of all patients that are at any risk really for outpatient procedures, or and all inpatients will also be tested shortly. So we're trying to create a sanctuary of patients and healthcare workers working within the walls of Stanford Medicine that we know are safe. And that's the goal. So I'll leave it there. Thank you.
Thanks, Dr. Rizk. That's really encouraging news. Next, we'll move over to Dr. Mahoney. Megan, I wanted to mention last week that we're really happy to have you as our new Chief of Staff at Stanford. So thanks so much for joining us as usual, and I'll turn it over to you.
Thanks, Errol. Good morning, everyone. So over the last week, we'll present my slide. Yeah, here we go. Over the last week, both radiology and the interventional platform resumed their services in support of ambulatory care across Stanford Medicine, following the recommendations of both CMS and the Office of Governor Newsom. Court has convened both the procedural operations ramp-up team and the ambulatory transformation team task forces to design and implement reactivation strategies across all three entities. These are really opportunities, along with related activities that are happening within the Department of Medicine, to incorporate a new model of care delivery that would serve us post-COVID and beyond. I was appreciative of all of the medical directors who responded to my request to give me a taste of what the clinics are doing to ensure the highest safety and quality in the practice environment, and was pleased to see these remarkable results led by Dr. Chang regarding the universal screening of healthcare workers. Also, as we know, we have universal masking, symptom checking that's happening at the entryways in the clinics. And then also there's a discussion about which cases are more appropriate for telehealth versus in-person care going forward. So all very exciting discussions, and I know we're going to learn from each other going forward. I was also very interested in hearing about the ways in which clinics are planning to re-engage patients in routine care and also in chronic disease management so that the semi-urgent care and all of those medical needs are met and there are no more delays for our patients. And then just a quick reminder that we have a fantastic e-consult program in collaboration with all of these specialties that are listed here. And Dr. Olivia G., who is the medical director of the e-consult program, reminds me that there will be more services that are coming online: hematology, pulmonology, potentially oncology. And so this is just an incredible example, another example of a way in which all of us collectively are working together as a system to allow us to manage a broader range of services for our patients and to meet their needs, while hopefully also saving patients an unnecessary doctor visit. And so finally, I'll offer one thing to do to combat quarantine fatigue. especially in light of the recent extension of the shelter-in-place order through May. And that is to look at and I'll send out a link in the chat, latest story bank audio story, which features a patient with a chronic illness and his daughter. And this is in recognition of this being Patient Experience Week. And it's a way to honor the people who are improving both the patient experience and also the families who take care of those patients. Thank you.
Thanks so much, Dr. Mahoney. Dr. Song Chang is the overseeing occupational health, and he is, as usual, will give us some updates as well. I'm going to stop sharing for a moment. I think you have a slide.
You're on mute, Song.
Thanks. I don't have a slide. Norm covered the headlines, and so I'll try to give you back some time, but I'll just make two interesting observations to share. One is that, as Norm pointed out, we have a very small number, around 40 or less than 0.4%, who are asymptomatic PCR positive. We don't know the infectivity of these persons, and as a precaution, we're asking them to stay home for 14 days. But epidemiologically, we haven't actually had any workplace-based spread or infection from these people as far as we know. And so probably their infectivity is extremely low. They're not sneezing and coughing. And so we have not actually seen anyone else that we're aware of that we could identify that got sick from being in contact with those folks. Again, as a precaution, we're asking them to stay home for 14 days. But we think that their infectivity is very, very low. The other, I think that's it. That's all I'll say for today.
Song, thanks so much. We'll move our next who's also doesn't have a slide, Dr. Nigam Shah, who thanks again for leading a great town hall the week before last, and he's going to provide some updates regarding modeling and some other related issues.
Well, a kind of modeling. Thanks, Errol. I mean, a lot of you might have heard about symptoms being non-specific and such, and I just wanted to give some color on why the universal testing that we have instituted as an organization is really important. So we did some analysis, which I shared on the town hall, showing the most common symptoms, the top 10, top 15, and so on. And subsequently, what we did was we calculated that if somebody wanted to reliably classify whether a patient or an individual has COVID or not, just based on symptoms, how many symptoms would you need to do that? Turns out you'd need about 20 unique symptoms to get there. And most medical records and conversations screening a patient ask for max 5 and upper bound like 8. Nobody goes above 8. And so at that level of symptoms, the maximum classification accuracy you can hope to achieve is about 65%. And then when we did the experiment, we tried building a classifier that just using inputs of symptoms and the known test results from the lab, if we try to build a logistic regression or something like that, that says COVID or non-COVID, it hits about 0.64, you're just under what the theoretical maximum is. And so that just gives you a sense that why such universal and broad testing is absolutely essential to run a safe operation as a healthcare facility. And then why the symptoms are interesting and a lot of groups are surveying people, try to get an estimate of prevalence. I think what we're getting is an estimate of the prevalence of some disease and not necessarily just COVID. So that's sort of the update I wanted to share. Thank you.
We'll move over to Dr. Ben Pinsky, who's going to provide some updates regarding our testing. Great.
Thank you, Errol. I just want to echo what Norm and Song were saying and really thank all the frontline healthcare workers for the incredible job that they were doing collecting all of these enormous numbers of specimens over the last week. And in the laboratory, we've been very busy performing all of those tests. You can see that the clinical lab has now performed greater than 30,000 RT-PCR tests. I'd like to highlight some of the tests from the asymptomatic individuals from the employee screening program. As was mentioned, it's about a 0.4% positivity rate. Very interestingly, most of these patients, as was indicated, have probably are not shedding a lot of virus. So cycle threshold values are inversely related to the concentration of virus in the nasopharynx. So late CTs are associated with lower amounts of virus. So you can see there the median CT value is 38. So these are all late, except there were 3 individuals with relatively high virus loads, CTs in 20, 21, 26. So those individuals may still be shedding quite a lot of virus. So that's an interesting finding, and we'll have to continue to monitor that. And then another thing I wanted to update the group on is there had been some concerns about the performance of the Gene Expert stat instrument or the rapid RT-PCR testing because we weren't picking up a lot of positives. I think that was primarily due to the population of patients that were being tested through that method, as Sam was starting to show in his first slide. We've confirmed that the performance of that assay is the same as the commercial Panther Fusion and our Stanford emergency use authorization assay. The positive percent agreement is 98%. So very good performance. So we don't have to worry about negatives from that assay that we're missing significant numbers of cases. And then finally, the last point here to kind of go along with this reopening that we're going to talk about later, the Expert Express instruments, another smaller version of the Gene Experts, they're being rolled out to Redwood City, Emeryville, and South Bay, and should be up and running by early next week, so that we will have rapid testing at those locations to support the patients and operations there. So thank you. And I think Scott is next with some serology.
Thanks so much. Thanks so much, Ben. Yes, and we have one last quick update from Dr. Scott Boyd regarding serology.
Yeah, thank you. And so as has been noted, initially we hadn't had too many people ordering the serology tests, but that problem has been resolved fully. So we've had, a couple thousand samples a day ordered, I think, and we've been testing them as quickly as we can. So the results, as Sang also gave, this is slightly updated from that, or Dr. Rizk. In the occupational health testing, we found that 96% of the samples were negative. About 0.7% were IgM and IgG positive, both, 0.7% G only, and then this 2.4% of IgM only. So many of these IgM only results, I should say, are close to our cutoff for positive. And so we've been adding a comment to recommend retesting in a couple of weeks for those. And we're also evaluating all the positive samples that we get offline with other viral antigens and things to sort of get an even better understanding of the performance of this testing. So that's something we should be able to give updates about in future rounds. But thanks to the lab staff who've really been pulling out all the stops to get this testing done. And I think that's a sufficient update for now. Thank you.
Oh, great. Scott, thanks so much as usual. Again, thank you to all the panelists, including those of the panelists who are on with us today that don't have updates, but are providing answers to the questions. So extremely, extremely important and valuable. So thanks so much for everybody else being part of this as well. I think we have Ann Weinacker, Lucy Tompkins, Abraham Verghese. So thanks for joining in the background here. I'm going to turn over now to our featured presenters. Today we have Dr. Doug Owens, Dr. David Studdert, as well as Dr. Maria Polyakova. Dr. Owens is special for me because I've known Dr. Owens for, over 11 years. He was my clinic advisor when I was a resident. And he's done so many great things over the years. All our residents have been so proud of him. He's the director for Stanford Health Policy, as well as the Center for Primary Outcomes Research. And so he's going to be talking along with Dr. David Studdert, who's a professor of both medicine and law. I don't know Dr. Studdert very personally, but I feel like I know him really well because over the years, as a communications person, I've heard of so many of the great stuff he's done. And so it's such a pleasure to have him. Lastly, Dr. Maria Polyakova, who is a professor, a PhD, assistant professor at Stanford Health Policy, as well as has a PhD in economics from MIT. We're so lucky to have this combination of talking to us about the healthcare policy in the setting of COVID. So thanks so much for joining us. Doug, I'll turn it over to you now, and let me know if you'd like me to share slides or if you guys got it.
All right, Errol, thank you so much. Can you hear me okay?
Yeah, perfect.
Thank you for that very kind introduction. Let me see if I can share my screen. Let's see here. All right.
Perfect.
Can you all see those?
That looks good. Perfect.
Oh, good. All right. So thanks again for the introduction. I'm going to give a brief overview. We're going to talk about sort of the policy issues surrounding reopening. And I'll do an overview. David will talk about some of the legal and ethical issues, and Maria will talk about an economic framework for reopening. Clearly, this has been a very controversial issue. Some states are now currently reopening their economy. And what we want to do is kind of think about what are the challenges as you do that. So I want to go back to sort of the basics of infectious disease transmission, because I think that that's something that will really help us inform what we do and what we should be looking for. So I'm going to start with this very simple sort of mathematical model of an infectious disease. This is the way many of them are structured. These 4 blue boxes here indicate different groups within the population. So in the case of COVID, everybody starts off susceptible, then you can become infected, then you either recover or die. And now when I show you this graph, if you look at this, the y-axis of this graph is the number of people who are infected. The x-axis is time. And if you can see my cursor, take a look down here at the origin. This red line is the number of infected people. And things start off very slowly, but then you get this explosive growth in the number of cases. This is just a hypothetical model, but this is exactly what we've seen in terms of COVID. And another way to think about the speed of transmission is to talk about the doubling time. The doubling time is just what it sounds like. How long does it take to double the number of cases or the number of deaths? This is a graphic from the New York Times earlier in April. The y-axis here is, on this side, on the left panel is cases. This is a log scale. The right panel is deaths. And then on the x-axis, you have time. This is days since your 200th case. Focus on these gray lines, and the slope of these lines is what's important. So for a line that has a slope like this, cases are doubling every day, then every 2 days here, every 3 days, etc. And let's take a look at this line from New York. And what you see is, based on the slope of this, there were times that about when they instituted their social distancing, where their number of cases were doubling every 2 days or so. Now, that's confounded by how much testing was going on, but you also can see over here that deaths were doubling every 2 days at times. So think about that for a moment. If you have a doubling time of 2 days, if Monday you have 250,000 cases, then middle of the week you have 500,000, and by the weekend you have 1 million. And so the speed is astonishing. And that is going to have to be a challenge for us as we try to reopen the economy. And that's what much of the thinking has been about, is how do you deal with the fact that you could get this very rapid resurgence? So what happens when social distancing ends? So this is a graph, an illustration from one of the early models that came out. There have been critiques of it, but I just want to use it as an illustration. The y-axis here is clinical care beds occupied. The x-axis, again, is time. And this bluish area is when you're doing some kind of social distancing. The black line is if you don't do any social distancing. And so you see this very rapid surge in cases. This is essentially hospital utilization. But with the social distancing, these lines stay fairly low, so you're kind of keeping a lid on it. But then you stop social distancing here, and of course, then within a month or so, you see this rapid resurgence. I just want to make a point about hospitalizations, and that is that they lag behind the infections that are occurring by 2 to 3 weeks. So if you're just depending on hospitalizations to know how you're doing, you could be way, way behind where the transmission actually is. There are two sort of major public health response strategies. Mitigation is really just trying to keep the lid on it. That's really what we've been doing, trying to keep healthcare systems from being overwhelmed. Containment is a more aggressive strategy where you're really trying to get the case numbers down to where you can contact trace and isolate and quarantine people. It's much more aggressive. This is the kind of thing we might have been doing in January had we known there was circulation and had we had the testing that we needed to do that. So in terms of reopening, there are many plans. There are several common elements of these plans. Most of them are staged and have some criteria for moving from one stage to another. The availability of widespread testing is a feature in pretty much all the plans. I just want to thank Scott Boyd and Pinsky and their colleagues for what they've done. It's been an incredible contribution that we can now do this testing. The testing is your early warning system. Harvard recently released reports suggesting we should be able to do 5 million tests per day by early June and 20 million by late July if we want to do adequate monitoring. I'm not vouching for the numbers, but the point is it's a lot of testing. Then the other main element is the public health capacity to contact trace, isolate, and quarantine people. And this is a proposal from former directors of FDA and CMS. And they proposed to Congress that to do this adequately would require $47 billion. So these would be massive, massive efforts. No one is doing this or able to do this at this time, but that's the challenge in terms of the public health side. I've been talking about public health side, but of course, reopening has many other policy challenges, the economic devastation that we've seen, and legal and ethical. And so with that, I'm gonna turn this over to David Studdert, who will talk about legal and ethical issues.
Thanks, Doug. I'm gonna try to share my screen here. How's that? Can you see the screen and hear me okay?
Yes, perfect, David.
Great, thanks, Errol. So I was just going to talk a little bit about the relationship between opening up and testing and focus in on a couple of the sort of legal issues and ethical issues that are emerging. As many in this group know, there's a balancing act at the heart of all of the hardest problems in public health law and public health policy. And that involves weighing the benefits of intrusive action to protect the population's health against the tremendous value we all place on being free from interference, particularly government interference. Since around mid-March in California and in many other parts of the country, that balance has obviously been tipped very strongly toward intrusive action. It's probably not a situation that can last for months on end, as all of us are reading in the newspapers. Maria's going to talk a little bit more about that. Right now, we seem to be entering the end of the beginning phase of the crisis. As some states move to loosen their restrictions, the balance is starting to be reset. So there's broad consensus that testing is really a key piece of that reset. Much more testing than we're currently doing, not in Stanford, but in the general community, has the potential, I think, to help us move away from these blanket restrictions and towards a set of disease control measures that are much better calibrated to risk. Now, that may be risk at the individual level or at the community level. But test results don't exist in some kind of clinical vacuum. They summon a response of one kind or another. So the question is, what are those responses going to be as we try to open up? The playbook for positive viral tests is pretty clear. It's very likely to be the one we have now. Those with mild symptoms are asked to self-isolate, and those with more severe symptoms will hopefully receive treatment. But what about antibody tests? What is going to be the response to individuals who test positive for antibodies? I think the answer is not at all clear at this point. The first thing to say here, and it's a point that's been made by Scott and Ben and others repeatedly in this forum, is that there is a lot of scientific and clinical uncertainty that still surrounds the antibody testing. Really, two major pockets of uncertainty here. First, it remains unclear whether prior infection confers immunity, and if it does, for how long. And second, the antibody tests coming online appear to be of, let's say, uneven quality. So after the slow rollout of viral testing, a bit of a fiasco really, the FDA has largely backed away from regulating serology tests. It's invoked its emergency use authorization procedures, and the agency is asking developers simply to notify their test, declare that the test is valid and accurate, and make the appropriate disclosures to people who get the test. There are getting up close to 150 tests now that have been notified to the FDA for antibody testing. Many of them were developed abroad, and the developers are starting to market them aggressively across the country. And as many of you are aware, preliminary evaluations indicate that some of these tests show pretty poor performance on sensitivity and/or specificity. So with the uncertainty about immunity and the test quality issues, the prudent course for now is probably to hold off linking any significant policies or programs to antibody test results. My bet is that that prudent approach is not going to carry the day. As the wave of antibody tests begins, there are leaping hopes and expectations here for how these test results are going to help with the balancing act and with the opening up. The proposal getting the most attention at the moment is the immunity certification, or so-called immunity passport programs. And the idea involves publicly or privately operated systems where individuals who can present proof of antibody tests, positive antibody tests, are going to be rewarded with looser restrictions. So individually calibrated responses. Chile is moving forward with such a program this week. Germany, Italy, and the UK are considering it, and the White House task force has said it's under active consideration. WHO has come out saying the evidence does not support this kind of approach. However, I think we should prepare for the possibility that whatever the federal and state governments in the United States decide to do here, the private sector may well move forward with programs like this. When they do, I think there are some things we need to worry about here, starting with access. As long as antibody testing is ramping up and supplies are limited, there should be an appropriate program for granting access. Reliable antibody testing should be prioritized, just as virus testing has been, I think, to frontline healthcare workers and first responders. Costs shouldn't be a barrier, and they may not be. It's quite remarkable that the US is pretty close to universal first dollar coverage for novel coronavirus testing at this point. There are claims that immunity certification would be discriminatory. That is probably not true in a legal sense. If they are implemented even-handedly, there are likely to be few constitutional or disability law barriers to differentiating based on immune status. It's something we do with other kinds of ID certification, areas like international travel and healthcare workers, and the courts have generally endorsed these types of certification programs when the risk is substantial. There's lots of historical precedent for worrying that tying advantage to some form of fitness is going to amplify disparities. Critics are already warning of Orwellian certification regimes. A new form of social apartheid is something I read about yesterday. These are serious concerns for sure. But the picture is a bit more nuanced, I think. Firstly, any immunity advantages wouldn't necessarily have to create a permanent underclass. They could be transitional until an effective vaccine. Secondly, it's already clear that infection has tracked a familiar path, with racial minorities and poorer communities bearing a disproportionate burden of infection. That should mean that antibodies are going to be more prevalent in these populations. So in conferring these temporary advantages, if we can get the science right, it's possible that immunity certification could conceivably operate more as a class leveler than as a class divider. The programs are going to need to guard against fraud. I think the standard set of security tools we use for other important documents should help to guard against forgery and things like that. Physician verification requirements could help too. Incentives for deliberate infection in this kind of program are a more difficult problem. Now, COVID is a very different kind of disease than, say, chickenpox, so perhaps we shouldn't fear the pox parties, but ultimately we may need to tolerate some level of perverse behavior, just as we tolerate and try to minimize the kind of destructive incentives that come from programs like fire insurance or life insurance. Finally, if oversight of antibody testing doesn't improve, I really think it needs to, any certification program is going to be vulnerable to all of these problems. Regulators and employers are going to need to guard against test shopping and a race to the bottom by developers in test quality. I think we need consensus standards for acceptable test accuracy, and we're going to need a mechanism for gathering all of these test results from across the country into one place to support surveillance and research. It is strange to be making these forecasts and worrying about these problems. I think 6 months ago, much of what I've just said would have sounded like bad science fiction, but we likely are approaching a moment when we'll need to confront them, so policymakers should plan. Let me stop there and hand over to Maria.
Excellent.
Thank you, Doug and David. David, I think you, yep, okay.
Great. And Maria, and as Maria puts her slides up right now, just wanted to send a reminder, thank you to everybody who is putting in your questions. We will continue to answer them live. And if you do have any questions directed to Doug, David, and Maria, I'll also try to pull those out, though I know a lot of those overlap with many of the questions that have been coming up. Thanks, Maria.
Great, thank you, Errol. Do you guys see my slides? Is it working?
Yes.
Yeah.
Okay, perfect. So David and Doug have already highlighted a lot of different trade-offs that policymakers are facing in this very challenging environment. So what I want to do here in this several minutes is to introduce a framework that is usually used by economists, both in research as well as in evaluation of many different policies, not just health, public health related policies, but essentially any policy, any public policy that governments have to make decisions about. And that framework is social cost benefit analysis. So let me just give you a very sort of two-sentence overview of what this is. So usually we try to come up with a full list to the extent possible of possible benefits and harms for everyone in a society. So trying to take into account disadvantaged communities, different racial minorities, everyone in the society that we can think about. And then the idea is, or sort of the trick of the social cost benefit analysis is to address the question of needing to make comparisons across a variety of very different domains. The trick is to translate all these measures of benefits and harms into monetary units. And then the decision-making rule would be very simple. You adopt a policy if benefits are larger than harms. So to give you kind of an example of how this type of thinking may go, for instance, in a preprint last week, Fritz et al. Are estimating that in California, about 1661 deaths were averted in the first 4 weeks of shelter in place. At the same time, about 400 jobs were lost per life saved over the same time period. So to put these two things in comparison in a social cost benefit analysis, we would try to translate both of these numbers into dollars to enable us to at least start talking about policy trade-offs. Otherwise, you end up with very different measures across very different domains. So one key thing that people frequently sort of forget in the cost-benefit analysis is that we never want to do this in a vacuum. Instead, it is very important to be clear about what is the policy A we're considering and what is the clear alternative. So we want to know the benefits and harms, not in absolute sense, but across various options that we have. So for instance, this this type of thinking in March would have been, you know, should we introduce a shelter-in-place policy or should we allow for an unmitigated pandemic? And there were important questions about morbidity and mortality of the virus and the treatment capacity at that point. Today, the question is essentially reversed, which is, should we reopen the economy and reduce the shelter-in-place stringency or continue sheltering in place? And as David and Doug pointed out, a lot of questions surrounding this are around whether we have enough treatment and testing capacity, and at the same time, whether the economic consequences of the shelter-in-place orders are manageable. So with this framework in mind, let us just try to go through the kind of cost-benefit analysis exercise that we could do for the shelter-in-place policy. So let us first think about benefits of shelter-in-place. These are quite clear. So the intended benefits of shelter-in-place is the reduction in COVID-related mortality and morbidity, as well as prevention of healthcare system collapse. We can also imagine that there are some unintended benefits. We are likely to observe fewer deaths from accidents and pollution as people reduce their economic activity, as well as possibly permanent changes in how people work that might also be beneficial, along with many other things. This is obviously a very incomplete list. So people have started trying to estimate some of these objects. So as I've mentioned, there is this recent study that was released as a preprint. What they're trying to do here is to simulate what would have happened to California if there were no shelter-in-place order implemented in March. And a distinctive feature of this study is, rather than using an epidemiologic model to do this forecasting, they're using some statistical techniques to aggregate the experience from other states to generate this blue line of what would have happened in California. And what they're finding is that there are about 1,661 COVID deaths that were likely averted by in the first 4 weeks of the shelter-in-place order. So these are the types of measurements that you would need for every type of cost and benefit to do this sort of cost-benefit analysis. So let us now move to the harms. There are certainly several types of harms that we may think about. Health-related ones are probably going to be familiar to many of you. These are foregoing medical care, or potential increase in so-called deaths of despair, or essentially suicides, where people may be worried about their economic conditions or family situation. And then there are several harms that we may think about in the economy. So let me spend a little bit more time on that since it's maybe less discussed in this audience. So the most salient one is obviously a strikingly rising number of unemployment claims, suggesting that there is a big rise in unemployment in the society. Loss of savings accounts due to stock market volatility that might prevent some people to retire on their schedule or might cause a lot of distress. Bankruptcy of businesses, including financial problems in the healthcare sector. We are expecting potentially a recession. It's hard to know how long or how deep it is going to be. Large increase in government debt that is likely to affect not only us today, but also generations to come, as well as loss in tax revenue for both federal and local tax collectors that also fund social programs, and we'll have to figure out how to make up for that revenue to keep these programs afloat. And then finally, we can also think about possibly important, but likely sort of less, these are things that are being, people pay less attention to because they might materialize only later in life. And these are missed kindergarten and school days, so missed instructions for students. And then for students in colleges that are now entering labor markets in this year, we know from the literature in economics that entering labor markets in weak labor years might be detrimental to their careers. So these are all the types of things that policymakers and economists worry about and try to estimate to try to have a sense of the harms of the policy. You can see here some attempts at these estimates. For example, this is a McKinsey forecasting, but it is in line with a sort of Congressional Budget Office and other calculations. This is showing the changes in US real GDP historically starting from 1900. And you can see that the forecasts here for GDP drops related to COVID are about a drop of 8 to 13%, which would put it to be a largest recession since World War II. Now, of course, we'll see to what extent these numbers actually are realized. So with that, I'm going to close here just by saying that there are a lot of trade-offs that policymakers are facing. These are hard questions and a lot of things to think about at the same time. Thank you.
Maria, thank you. Doug, David, thank you as well for that very thoughtful conversation. It's definitely something that's being probably one of the most talked about thing in the news today. So thank you for bringing that to attention. I'm going to ask the rest of the panelists to join us back now. We do have a number of questions, and I think a lot of the questions kind of, we have a lot of questions on things that you guys touched on. Testing is a big one. I'm just going to go through some various questions, and some of them may be best answered by you guys or the rest of our panelists as well. Oh, here's one to Dr. Polyakova. I thank you for this info. The data talks about deaths averted in California. Any info on number of hospitalizations averted?
Yeah, that's a good question. So the paper doesn't report hospitalizations. They do report cases of infection. So I guess knowing the hospitalization rates, we could calculate that, but I don't have the number off the top of my head.
Okay, thank you very much. And so I'm going to go through some of the questions here. I'm just going to actually start at the top of the remaining questions that have not been answered by our panelists already. Again, thank you to the panelists for doing that. And I may go back to just a few of the answered ones just to highlight those, because many of you may not have had the chance to read the answers that have been put up there as well. Actually, maybe Song, this might be a good question for you. There's numerous apps out there for contact tracing, some made by Stanford students. Is that something that we may be using in the future more formally, particularly as the university starts to open? I know that Song, the group has been looking at all sorts of ways to look at this, and the focus has been, of course, largely on testing as that expands, and there's been lots of questions on that as well. Thank you for answering. Any additional thoughts on how we might use apps?
Sure. Sorry, my video is frozen, so I'm still here, but you can't see me. I think that there are a lot of sensitivities and social concerns related to the widespread institutional use of some of these apps and their effect on privacy. That said, there's one technology that we're exploring that could be very helpful in very concrete ways. We have the RFID badges for SHC employees that can give us a tremendous amount of information about who was in close proximity with a ill healthcare worker and for how long and roughly in what proximity. And so that really helps us a lot with contact tracing to follow up and contain any potential clusters or outbreaks. Beyond that, I'm not aware yet of a plan to adopt them more widely, but maybe others on the panel do.
Great, thank you. Thank you so much. So we'll move on. This is an interesting question that a lot of people have been asking. I don't know if anybody here has the answer to it. Is the virulence of the virus lessened in regions of the world with higher temperatures and high levels of humidity? That's been an ongoing question. I think we'll find out in the coming months. Norm, I know you're smiling a little bit. Any insights to this?
I think there are data that support that it's less communicable and that it resides less or not as long on surfaces in hot, humid conditions. I don't know anything about virulence, though. I would guess it's an infectivity question or contagion question.
Yeah, I think it's controversial, and we'll certainly find out upcoming. If we get more information on that, we'll certainly include it in the email we send out later today. I'm interested myself. There's been a lot of questions, and again touched on in our main talk about the importance of large-scale testing. And a lot of the questions have been practical ones, understandably so. And I don't know if this one has been already answered already in the questions, but I wanted to bring it up anyway. Perhaps to Norm or to Song, there's been questions about, are we going to do more universal testing, both at the university level and then largely just all over? There's been questions about testing grocery workers, just testing people in general. And that's our goal. We've been scaling up testing tremendously here. Yeah.
I can speak to it and then maybe Song. So we are scaling it up to the community in various ways. We've been looking in hotspots in skilled nursing facilities on Galvez Field out on the main campus. We've been testing first responders, and the testing committee of court has been deciding what the most appropriate community outreach would be. In terms of the periodicity of retesting, that's something that we have discussed. The current status is once our healthcare workers have been tested, we're not retesting them unless they're symptomatic. That would obviously miss asymptomatic new infections, and so that's a major concern. And I think the periodicity would have to be based on the community prevalence. And there has not been a decision about when healthcare workers or other people should be retested based on that. And the prevalence is obviously, we hope, diminishing in the community. I just want to say one word about the prevalence in Stanford Medicine and Stanford Hospital, which is we only had 9 patients today in the hospital that are confirmed COVID patients. We haven't done an intubation in a patient at Stanford Hospital in the last 30 days. and we only have 1 in the ICU. So this is quite fortunate and does speak to diminishing referrals, at least to Stanford Hospital, of ill patients.
Thanks, Norm. Song? Any other comments?
The only thing I would add to that is that there's a lot of strongly expressed interest in various parts of our Stanford community, our School of Medicine lab and research staff, and then the larger university to be screened, even asymptomatic. And I think there's going to be value in public reassurance and confidence in doing that asymptomatic screening, whether or not it has any medical or epidemiologic impact may be a relevant but not the solely determining question of how much testing we do, because public confidence and our staff's confidence in returning to work is really, really an important goal as well.
Thanks, Song. We got an interesting question. Perhaps, Maria, the answer to the question is, I'm 93, have 7 grandchildren in the 30 to 40 age group. Our value to society is different. How do economists measure this? Kind of a tough question, but interesting.
Yes, that's an interesting question. So, and we can have a whole lecture about this, and I do with my students, but the short answer is the technique used for this, both by economists in research as well as by many agencies, for example, environmental agency uses a lot of these techniques, is called value of statistical life, where the idea is that you're trying to measure the how much society is willing to pay to reduce mortality risks, and you can adjust those for ages. So there are techniques to do that. Most commonly, the way it is estimated is by comparing people in different occupations and sort of how much you have to pay people more in order to take up a riskier occupation. That's kind of the most common estimation strategy.
Okay, great. Thank you so much, Maria. Michelle Berry, I'll go to this next question I was going to go to next. That's an interesting question. Have you calculated unrecognized benefits of COVID-19, lack of traffic accident deaths, less pollution, cause deaths? There have been calculations in China for COVID time, less deaths during this period as a result of less pollution. Is that looked at? I don't know if Maria, or from your perspective, certainly other perspectives like Nigam or Song is nodding his head as well. Any thoughts on that? I know it's a tough one to look at. I'm not sure it's something that data has been generated on that yet. I imagine it will be over time.
Yeah, it's a hard question to answer. I don't know whether Nigam has any thoughts.
Yeah, I think it's a tough one. I think that's one we're going to hold for the future when we do undoubtedly will have more data on this. I'm sure it's going to be a popular topic once we know more about it. Michelle, thanks for that question.
The thing I'll jump in here is to say that in the US, this analysis is ridiculously hard because we make it nearly impossible to get good, reliable death estimates in our country.
Fair enough. It's helpful to know. Winnie asks, is there any estimate of how many lives will have been lost due to patients without COVID delaying care? So the care of patients that we've delayed. Norm, I know this is something that's very big on your mind and overseeing it. We're slowly opening up the hospital as soon as possible. But I don't think we have numbers or estimates along those lines. I think, Nigam, that's something that is difficult to do as well, I imagine, at least at this point.
In Seattle, I know that there was an increase in mortality from myocardial infarctions and vascular events, probably because of deferred care. But I don't know any real numbers that we could say in our environment. Obviously, it's a concern.
Sorry, go ahead. I just wanted to jump in on this, saying that I think we're expecting data to be released from the Social Security Administration on deaths in June from all-cause mortality. So we'll be able to measure the changes in all-cause mortality. Unfortunately, that data doesn't yet contain diagnosis. So once that becomes available, probably around September, I think there will be some numbers on that. But for all-cause mortality, I think in the summer we'll have better numbers.
Errol, I'm going to make a quick comment on this because from the American Heart Association perspective, we've been commenting on this a lot. that there's an estimate that there's about a 30 to 50% decline in acute myocardial infarction care being sought. And we have that tracked through nationwide EMS data, where you can look at why people are calling 911. And there's been a marked decline in 911 calls for both stroke-related symptoms and heart attack-related symptoms. We have big registries called Get With The Guidelines in 2,500 US hospitals to track all the cardiovascular and stroke issues in the large amount of US hospitals that take care of these patients. It runs about 2 months behind from a data collection perspective. So we expect, as Maria has also suggested, in June that we'll get the first look from February, March, and be able to begin to, and maybe even part of April, to begin to understand what actually happened. The anecdotes are that people don't want to come in, but that's not hardcore data yet. But it's pretty uniform, and there was a paper coming out of Italy that suggested a decline in hospital admissions for acute coronary syndrome. So I think very much more to come as an unintended consequence.
So one thing I would like to share, I mean, we have about 1,000 people on the call and the panelists here. Like, what can we do to reduce the data lags in our systems? Like 2 months later, or getting all-cause, cause-specific mortality by September. I mean, all that allows us to do is a postmortem. We can't do any planning.
Yeah, I think that we've been talking about this from the cardiovascular world perspective. The challenge is, Nigam, as you know well, there's a complete lack of interoperability across the electronic health records for the United States, and how we could improve that so that data dumps directly from the EHR into the registries, which are available for reporting, would be a huge help. PCORnet does some of this, but it doesn't grab all of the data, because it takes and puts that data, as you know well, into a common data model and forces it out that way. But it's this lack of interoperability that's really the big obstacle.
Thanks so much, Bob. As we end, I perhaps might end on this last question. David, perhaps you can answer. There's been a lot of news articles you hear about someone testing positive, and then the neighborhood's trying to keep them in their house because they're worried about spreading the virus. Someone's asking, are there legal implications for someone who tests positive and refuses to self-isolate? Any thoughts on that?
Well, I think as many in this group know, the enforcement across the country has been fairly light. And so there aren't a lot of cases being reported of people who've been detained or forced to adhere to certain measures. I see in the paper this morning that New York broke up a funeral yesterday. But on the whole, what we've seen in this crisis has been a light touch from public health authorities and law enforcement. And whatever the intricacies of the legality associated with breaching restrictive orders, I think thankfully counties and cities have decided that they need to deploy resources doing other things and not monitoring. So it really is a kind of social compact where we're asking people to adhere to these orders and hope they will. But thankfully, it's not come to any strict enforcement at this point.
Thanks so much, David. Doug, David, and Maria, thank you again for the talk you gave today. Very thought-provoking. As usual, to all our panelists, thank you for your time and being with us, and thank you for everybody joining us this morning. A lot of good questions just came up towards the end. I'm sorry we didn't get to them all. We'll try to get the answers out to you later today. Thanks to Joy for doing the bullet point summaries for us every week. And I hope everybody has a great week, rest of the week, and we'll see you next week, okay? Thanks so much.
Thanks, Gerald.
Bye-bye.